There we go. Here are my financial disclosures. All right, so small cell lung cancer is a highly aggressive malignancy. It makes up about 15% of all lung cancer, and unfortunately, the majority of patients present with extensive stage disease and are thus not curable. Now, while we've heard a lot of exciting things both today and yesterday regarding the revolutionary breakthroughs in the treatment of non-small cell lung cancer, we really haven't had as much advancement in small cell. The last drug that was approved was topotecan in 2007, and that was hardly a blockbuster in terms of efficacy. Here is just looking at the survival data, and of course, in limited stage disease, the median survival is about 2 years. And if you get to extensive stage, which is what most people are presenting with, the 5-year survival is less than 1%. So there is certainly room for improvement with this disease. So what's the current state of our care for patients with small cell lung cancer? Platinum and etoposide remain the standard of care, at least within the United States. And there have been multiple studies to try to add a third agent to improve the outcomes. Most recently, a hedgehog inhibitor, an IGF-1R inhibitor, and neither of them improved outcomes in any meaningful fashion. So platinum and etoposide remains our standard of care, both in limited and extensive stage. Maintenance chemotherapy, something that we heard a lot about earlier today, also does not seem to improve outcomes. So patients get 4 to 6 cycles, and we know it's going to come back, but further chemotherapy just adds toxicity and does not improve outcomes. We then give people prophylactic cranial irradiation or consolidative chest radiation. These are some advances that have been made in terms of moving the needle a little bit. Topotecan is currently the only FDA-approved second-line agent for the treatment of small cell lung cancer. Most recently, it was compared to amrubicin, and amrubicin was not better than topotecan, but you can see that both of them have a median overall survival that is not very good. So there's a lot of room for improvement in this disease. So I want to talk about 3 areas. So the first is novel cytotoxic agents and combinations. The next is immune checkpoint inhibitors in the treatment of small cell lung cancer, which Dr. Gadgil is going to talk about shortly in non-small cell lung cancer. And then emerging approaches sort of outside the box. So first, novel cytotoxic agents. So why is small cell lung cancer so hard to target? We just heard a lot about various targets that can be found in non-small cell lung cancer. We heard about EGFR and ALK, and in the most recent talk, we heard about rarer mutations which are found in non-small cell. And that's because when we look at that pie chart, we can find multiple small slices of pie that can be targeted with novel therapies. But small cell is a little bit different. If we look at the genetic landscape of small cell, what we see is that 90 to 95% of people have either a P53 or an RB1 mutation. These are tumor suppressor genes, not oncogenes. So the analogy that I like to say to my patients is that if you have an on switch and it's broken and your light's always on, you can unplug the light. But if your off switch is broken, a bunch of lights might turn on, and it's a little bit harder to turn all of them off. And that's a problem in terms of targeting these tumor suppressor genes, turning off the off switch. PARP inhibitors are one thing that have been looked at in small cell. This is a DNA repair enzyme that has yielded promising results when inhibited in BRCA-driven tumors. BRCA is a DNA repair defect that's found in some cancer susceptibility syndromes. And basically what we find is that if we give a PARP inhibitor, those cells that are highly dependent upon PARP, meaning those cells that have deficient DNA repair, die more than regular cells. And that's why we're seeing very good responses in these BRCA-driven tumors. However, recent studies have shown that we're also seeing responses with PARP inhibitors in some other cancers, in prostate cancer, in pancreas cancer. Now, these cancers were looked at first because they're also occasionally BRCA-driven tumors, but the fact is that There's also DNA repair abnormalities in these tumors, even sporadic cases that are not associated with BRCA mutations. So then you think about small cell. We've got a tumor that's growing very rapidly, constantly having mitotic divisions, and there are going to be defects that develop in the DNA. So would it be a reasonable option to try PARP inhibitors in that setting? And that's the logic behind ECOG 2511. And this was a phase 1-2 study of cisplatin and etoposide with or without veliparib, a PARP inhibitor. Phase 1 has been reported with 9 patients, so pretty small thus far. But the phase 2 study has completed accrual. This was a randomized study, and it has not yet been reported. But here's a look at the preliminary safety and results from this combination. Based on the recommended phase 2 dose of 100 milligrams twice daily, we see similar side effects to what we see with cisplatin and etoposide. We're seeing some grade 3 and 4 neutropenia and thrombocytopenia, but nothing crazy in terms of a side effect profile. There were 7 of 9 patients had died at the time of the publication, but this is extensive stage small cell, and we were going over the prognosis of that disease. Here's a look at the responses for the 9 patients. We see a 14% complete response rate, 57% partial response, and 28.6 stable disease. I think that this is interesting, but you've got to put it into the perspective of what we would expect from cisplatin and etoposide by itself. And if you look, these numbers don't really make this seem like a slam dunk, that we're going to see a huge amount. But of course, it's still early. But from the NOTA data from New England Journal 2002, we can see that the complete response rate was about the same, partial response about the same. So it'll be interesting to see what the final results are, but certainly the initial reports don't seem that exciting. This may be more of a mirage than the therapeutic progress, but we'll see. But the Notch pathway is another pathway that has been shown to be important for small cell. The Notch pathway is enormously complicated, and discussing it in detail would be way beyond the confines of a 20-minute talk. But in general, Notch can increase tumor growth, it can suppress tumor growth, and in each tumor it seems to have a different function. But what we do know is that the delta-like ligand 3, or DLL3, is a key ligand for Notch, and it is amplified in small cell relative to other tissue. This is from Saunders' paper this year, Science and Translational Medicine, and what they looked at was DLL3 expression in small cell, in a small cell patient-derived xenograft, and in large cell neuroendocrine tumors. And you can see that the rate of DLL3 expression was much higher in those tumors than it was in any normal tissue. So this is a really nice target that we can get to even in the presence of all of that thing that we were talking about before with the genetic landscape. So rovalpatuzumab tesirine is a novel antibody drug conjugate. That antibody targets DLL3, and it's conjugated to PBD, which is a novel DNA crosslinker. I always think it's interesting when they call these things warheads, but in any case, the warhead is this novel DNA crosslinker that gets cleaved off of the antibody with cathepsin B once it binds to the site of the tumor. And a phase 1 study has recently been reported, 80 patients with some type of neuroendocrine tumor. Remember, we saw that there was DLL3 overexpression in both small cell and large cell neuroendocrine tumors. And this is the patient population. It's important to remember, these were second and third line treatment of advanced small cell and large cell neuroendocrine tumors before we look at the results. This is a highly pretreated population with a relatively poor prognosis. Here are the adverse events that were seen. These are the 2 expansion cohorts from the phase 1, and this is the recommended phase 2 dose. And so if you look here, it's pretty well tolerated. It's every 6 weeks, 15% thrombocytopenia, but that's pretty much it in terms of severe side effects. And here are the results, and this is really exciting. If you look at the intention to treat population, what you can see is that there's a 20% overall response rate and a 70% clinical benefit rate. But here we really have a biomarker. We have a biomarker that is meaningful, because if you look at the DLL3 high population, you're seeing a 40% response rate in the second line and a 38% in the third line. This is really exciting. Because if you consider the duration of response, this is greater than 182 days for the mean duration of response for those patients responding to this agent in a well-tolerated drug, third-line treatment of small cell. This could really be a game changer. The next topic I want to touch on is immune checkpoint inhibitors. And of course, we've been hearing a lot about these in the news recently for many diseases. But small cell may really be an ideal disease to consider immune checkpoint inhibition in. And the reason for that is that the two biomarkers, at least clinical biomarkers, that seem to be associated with response are first, a tobacco history, and patients with small cell generally have a large amount of tobacco history. And second of all, mutational burden. This was shown from Alex Snyder's work in CTLA-4 inhibition, where greater mutational burden is associated with a better response to immune checkpoint inhibitors. And here you can see the mutational burden in small cell is relatively high. So it's a disease where we might be able to have a juxtaposition of benefit here. So KEYNOTE 028 was presented last year at ASCO, looking at pembrolizumab in PD-L1 positive small cell lung cancer. Should be noted that only 28.6% of patients were PD-L1 positive in this disease by the assay. So here are the patients, standard patients, similar to what we've seen previously with prior treatment with chemotherapy for small cell lung cancer. And here are the results. This is this classic progression-free survival curve that we expect to see with these immune checkpoint inhibitors, where the exciting part is not so much the response rate. Okay, the response rate's 29.2%. That's good. It's exciting. But really what's exciting is the tail of the curve, where we're seeing that at 8 months, we still have 30% progression-free survival. Those patients who respond have durable responses. One thing that we have to remember, though, is this area down here, 25% not assessed. The majority of those patients who were not assessed had some form of progression before they could get to the first scan. And this may have been because of waiting for the staining, the PD-L1. So the other immune checkpoint inhibitor that has been assessed in small cell is in CHECKMATE 032, comparing nivolumab with or without ipilimumab, a CTLA-4 inhibitor. And they used various doses in this trial, but for the purposes of their analyses, they conflated them into either nivolumab or nivolumab plus ipilimumab. And these are the patients. This is a similar patient population to what we've seen the others, with 1 to 3 prior treatments. A pretty substantial amount of patients had been heavily pre-treated. 63%, 2 to 3 priors in small cell lung cancer. They were 55% platinum refractory. These are sick patients. And these are the results. Again, we're seeing in a PD-L1 unselected population an 18% response rate approximately for both nivolumab with or without ipilimumab. They showed an overall survival curve here. Again, the issue that's most exciting with immune checkpoint inhibitors is not so much where the median is, but rather this tail of the curve. That if we look at 15 months, we still have a 30% overall survival. And just to remember, this is third-line treatment, sometimes fourth-line treatment of extensive stage small cell. This is really exciting data from where I'm sitting. If we look at the rate of not assessed, it's lower than was seen in the KEYNOTE study, and that may have been because of the lack of the need for waiting for PD-L1 assessment. So in summary of checkpoint inhibitors in small cell, they seem to have efficacy with a relatively low toxicity. Larger trials are certainly underway. However, patient selection is really critical. We do not, as of this point, have a slam dunk biomarker for immune checkpoint inhibitors. And in a disease like small cell, where the disease grows so rapidly, we don't really have much wiggle room in terms of waiting to see if maybe this will have an effect. The combination with CTLA-4 blockade does increase the toxicity, and we'll need to take a look at the response rates overall to see how it will benefit. The concept of pseudo-progression is something we think about with immune therapies, and that concept in small cell gets a little hazy, because again, this disease grows rapidly. We don't have much time to sort of see if we'll get a late effect. Next, I want to talk about some emerging approaches in this disease. The Seneca Valley virus is a coronavirus. It's an RNA virus with no oncogenes, no chance to integrate into the genome, and has tropism for neuroendocrine cancer. So it sounded like a really great idea. This was a phase 1 study of large cell neuroendocrine and small cell, and they saw in 30 patients, no one had a RECIST response, but one small cell patient was alive 3 years after therapy, after rapid progression through multiple types of systemic chemotherapy. Unfortunately, the phase 2 trial through ECOG was stopped for futility, so I'm not sure what the future of this agent is. Alisertib is an aurora kinase A inhibitor. Aurora kinase A is a key regulator of mitosis, and remember I was saying small cell is rapidly dividing, so inhibiting mitosis may be a very reasonable target. This was a phase 1 study, showed a 21% overall response rate, all of which were partial responses, and the median duration of that response was about 4.1 months. And neutropenia was the most common adverse event. So this response rate it's nice. The duration could be longer. And so an ongoing phase 2 is combining this agent with paclitaxel to see if we can maximize some other effects. And finally, I want to touch on circulating tumor cells. I thought this was a really interesting paper that was published in JCO a couple years ago. So we learned yesterday a lot about liquid biopsies and how these may apply to modern oncologic care. Circulating tumor cells are a natural extension of that idea, such that you can draw blood and see a real-time marker of how much tumor is spreading throughout this person at any given time. And just intuitively, having tumor cells in the blood sounds not good, but this was a study actually looking at how that impacts prognosis. So if you look at patients with small cell lung cancer, first of all, 85% of them had detectable circulating tumor cells, meaning that this is a reasonable, viable test in this patient population. And those patients who had greater than 50 detected circulating tumor cells at the time of assessment had a much worse overall survival. If you look at the median, it is less than half of the overall survival. So then you say, okay, well, what about when you treat these patients? Could we use this as a biomarker of therapy? So it turns out that this is breaking it down into 3 groups. Group 1, in dark blue here, had low circulating tumor cells at the start, and then after treatment, their circulating tumor cells remained low. Group 2 had high circulating tumor cells and then went down with treatment. And group 3 had high circulating tumor cells at the beginning and then had high circulating tumor cells at the end. And what you can see here is that there's a clear stepwise decrease in the overall survival by virtue of their circulating tumor cell status. And what I think is really interesting is that they did a multivariable regression to evaluate what are the predictors of overall survival in these patients, factoring in things that we know are important for small cell, things like their stage, their performance status, how disseminated are their metastases. And when they included their circulating tumor cell status and the change thereof, none of these factors remained significant. So it was such a strong impact upon the overall survival that this may be a really key factor. And if we can drive our therapy based upon it, that would be a real step forward. So in conclusion, small cell remains a difficult disease to treat, but for the first time in over 10 years, we're starting to really see novel therapies with hints of efficacy, which is really exciting. There are randomized confirmatory studies currently underway, but I really feel that novel therapeutics with biologically important targets are key to improving patient outcomes for this disease. I thank you very much.